We're very excited to start tonight's talk. I'm Dr. Karli Goldstein, and we have two very exciting guests on tonight. So we have Dr. Aimee Eyvazzadeh, also known as the Egg Whisperer, or mainly known as the Egg Whisperer. She's from San Francisco Bay Area, and she has over 15 years of experience in IVF, egg freezing, fertility preservation. She has podcasts, books, and really exciting egg freezing parties where she educates thousands of people around the world on fertility science in a very approachable way that they can understand. She's established the Tushy method and all different little educational mnemonics that patients can use, special diets, a supplement guru, and has been featured on all the major news networks. And we're so excited to have her on board tonight. And we have Monica Wunderman, who is a content creator and a giant patient advocate who shares her journey to parenthood as she struggles with infertility and specifically with endometriosis, diminished ovarian reserve, and gestational surrogacy. Through her own challenges, she's harnessed really an entire platform and community of followers, and she has really passionately shared her story. She's also a huge outdoors girl who loves to hike, camp, scuba dive, and I love to vicariously follow her on her travels all throughout Spain, walking on the Camino, and all of her neat trips she goes on. So we're so excited to have both of you on tonight. Thank you so much for coming.
Thanks, Karli. Thanks for having us.
Thank you for having us both.
Absolutely. So we just wanted to start off tonight, Monica, if you will, share a little bit of your story and sort of your timeline, or what kind of brought you on this journey and what you sort of wish you found out earlier or knew about endo and your condition.
Absolutely. Thanks for having me. I'm excited to be here with my whole care team, pretty much. So you guys will get tied into my story. So yeah, my name is Monica. I am, I guess, an infertility advocate, but I started through trying to find help and solutions for myself, and kind of created this community accidentally through, I think, what other people are looking for, which is just information gathering and finding people that have things in common, struggles that they can identify with, and just sharing about my experience. So I think you can trace back the beginning of my journey to when I first got my period. It was horrendous. I was 12. And it continued to be horrendous to the point where in high school, I was missing school. I was throwing up. I was seeing different doctors and not really getting the support that I now know I needed. Back then, I was told that the pain that I was experiencing, the bloating, the stabbing pains were just like a bad period. And I think that's a really common thing that we are told when we don't have the right medical professionals and care team helping us, guide us towards finding solutions. And so I kind of just lived like that, not really knowing that there was anything to do, just kind of being told that like that is the way life has to be for me and it sucks. And then fast forward I think 13 years or so, I had switched to OBGYNs and discovered through a regular checkup appointment and pap smear that I had basically some reproductive abnormalities or anomalies. So I was born with uterus didelphys. I had 2 uteruses. I had 2 cervixes, which I never knew about. It took 3 OBGYNs to even get there with me. And we discovered all this about my body. I also had a kidney in my pelvis, all over the place, but nobody tied anything that I was experiencing to either fertility or I had never even heard the word endometriosis. So that was at 23-ish. And basically I was just sent on my way, these things are part of you and move on with your life again. And it wasn't until my husband and I started trying to conceive I think it's been about 8 years ago, that I started to learn more. I think things did not go well. I am still childless, been through IVF too many times. And eventually my journey led me to Dr. Aimee, who's here with us today. I've been a patient with her for about 5 years, and she was the first person ever, and I feel very lucky that I had her as my doctor, to ever like utter the word endometriosis to me. Like, I think I had heard the word somewhere, but like it was this like bringing everything that I had experienced kind of together to one answer, that might be the root cause of the terrible symptoms that I'd been experiencing for, 20 years at that point. And then also maybe potentially getting to the root cause of some of my infertility diagnoses, because I had been diagnosed with like low AMH, diminished ovarian reserve, and potentially egg quality issues, which I've since learned is all like tied to endometriosis. So that kind of began my journey towards finding care to like improve my quality of life, because it was really having an impact and just getting exponentially worse. And then also trying to find care that might improve my chances of being able to create beautiful little healthy embryos and maybe one day have a little baby of my own. But even from there, it took like 2 to 3 years and a lot of research and a lot of patience and a lot of conversations to find Dr. G, who performed my laparoscopic endometriosis excision surgery back in 2023. So that's like my story. From there, my life has like done a 180. I got to the point where I was in bed a lot of the time and not able to participate in things that I love. Dr. G mentioned hiking and outdoor activities, and I really was very bedbound. And since having surgery, like my life has completely changed. I was able to walk 800 miles last summer across Spain.
So much you got a stress fracture, right?
Yeah, worth it though.
Oh.
Those were things that like I never thought I'd be able to do again. And I remember telling you, like, I think in my delirium post surgery that like I was going to get back to these things, that like you'd given me a new lease on life, and I firmly stand behind that. Um, so, I mean, from my perspective, it took way too long to get diagnosed, and it was way too hard as a patient to try to find the right surgeon and the right information and battle with insurance and all of that. But it absolutely was worth it, because it's drastically changed my quality of life. And now I'm just trying to share my story and my experience in the hope that nobody else has to wait 23 years to get a diagnosis and support, and that people don't, feel so alone in the process. We found out through my surgery that I think we ended up, stages are a little subjective, but stage 2 or 3, I had endometriosis throughout my bowels, my rectum. I think, it was having an impact on that pelvic kidney. We actually ended up removing my pelvic kidney during that surgery. Maybe Dr. G will talk about that a little bit more later, but I've learned that, your symptoms don't necessarily equal your stage or the severity of your disease. I would say my symptoms were pretty severe, but it's nice to have that validation in the surgery that you actually like found disease and were able to identify it, able to remove it. And then I was able to then see like that big difference in my quality of life. So it's just like proof of what I had been living with and what I shouldn't have had to have been living with for so long.
And I wonder if for you, Monica, maybe people got so sidetracked by the didelphys and the uterine anomaly that then they sort of like had blinders to other things that could be causing pain, and so maybe they just blamed that as like, well, that's probably your cause of pain. And, and people do that a lot with things like PCOS or fibroids, even though they don't typically cause pain. So I feel like there's a lot of miseducation around
Yeah.
endo in general and what really is the root cause of pain, and I see PCOS patients all the time that are told that's the cause of pain, which is not really true. So I think maybe that caused like a big confusion and sort of, longer delay even for you, with
Probably.
sidetracked.
Yeah, I would say that's probably true. I mean, prior to finding out that I had uterus didelphys, it was being told by doctors like, oh, you need to go on an antidepressant, or like, you need anxiety medication, and just like completely discounting my experience. And then, yes, once I had this diagnosis of uterus diadelphys and the pelvic kidney, then yes, there was a lot of focus on just like the anomalies of just how my internal organs are set up. Um, and it's interesting too, because I hear in the uterus diadelphys community that like endo is definitely like strongly correlated.
Very.
So
Yeah.
interesting that nobody thought to mention that.
Yeah, actually, any uterine anomaly, so even a heart-shaped uterus, arcuate, bicornate, unicornate, didelphys, any uterine anomaly is strongly associated with endometriosis, or any sort of blood obstruction disorder where, bleeding may not happen normally. So,
Yeah.
so it's important for anyone watching that's a strong chance, So, um, and they're already asking some questions on how extensive was your surgery, and post-op, did you undergo suppression? So, I mean, I can tell them a little bit of basics, basically. So for Monica's surgery, there was basically in the beginning, we did cystoscopy, a bladder analysis. We put special green catheters and green dye up in the bladder and the ureters, since we knew we were going to be looking at the urinary system and the kidney. And then we did what's called a vaginoscopy, or hysteroscope, or a little camera inside the vagina on both sides, and at the cervixes and in the uterus on both sides, to really look and evaluate how these uterine cavities look, sort of live in camera. And then we recorded all that so we could watch it later and send it to Dr. Aimee to look at too. And so, and then we looked above at the same time in the abdomen, and with several surgeons in the room, and we watched the uterus from above while we were also looking below. And so that's called a dual compartment approach, or dual camera approach. And it's really great for complex cases like this, where we really need to be looking multiple places at once and keep everything safe. And then, there was extensive endometriosis, which was all taken out. And then also a pelvic kidney, which was actually twisted, and causing you a lot of pain and really malfunctioning, and not really that viable anymore. And so we did end up removing that pelvic kidney. And so in the same surgery, rather than waiting and coming back for that years later, So,
Yeah.
and so that was quite extensive for her. Recovery wise, do you want to say if you went on any suppression afterward?
Yeah. So no, I did not go on any suppression afterwards. You can probably speak more, Dr. G, about, why those choices were made. But from my understanding as a patient who doesn't know everything from a medical perspective, there are a few things. My symptoms like almost immediately were so vastly improved, but also we're still in the process of, trying to potentially create more embryos. So I don't think suppression was really something that we were looking to do necessarily. But yeah, I had my surgery, I recovered from it. And since then, I haven't really had to have like any support since. I haven't had to look at my, recent fertility panels or hormones. But I can say that, it's been, almost 2 years. Wow, that's crazy. So I can only speak to just like what my life has been like since, and it didn't seem entirely necessary, but you can probably speak more as to why that was the choice.
Yeah, Dr. Aimee, do you want to weigh in on that, on whether you think, we always talk about, what you're doing with your fertility rounds, whether, suppression is really necessary, or whether you can just go right into embryo creation, or, egg freezing and stuff like that afterwards,
Yeah, because suppression can impact your ovarian reserve, it puts you into a medically induced reversible menopausal state. I often do not recommend suppression before IVF stimulation, unless, however, someone has terrible endometriosis and we still need to sort of cool them off a little bit after surgery if there were deep nodules that we just couldn't get, and we want to, see a little bit more of a reduction in the endometriosis load, and decrease inflammation a little bit more before they stimulate. So I would say 98% of patients, I'll say no suppression after surgery before they do an IVF cycle. It's about 2% of patients might still need, and those are the patients who have extremely severe endometriosis before we start IVF, that they would need suppression.
And some may elect for birth control, right? And then you may time them with their birth control if they wanted to be on that afterwards.
Certainly, certainly, absolutely. If for some reason they need to wait to do IVF and they need, they need something to tie them over, then we can certainly use birth control pills or Orlissa. So there are different ways of doing it. I mean, Orlissa is a form of suppression, but it comes in different doses. So you can use a lower dose for a short period of time, and that can be helpful in some cases.
And what's the most common question we hear all the time is chicken before the egg question. What should you do first, egg retrieval or surgery? And everyone asks me this question every single day. I know you get it a lot, I'm sure.
Yes. I think it's egg retrieval for the most part first before surgery, because surgery, especially in patients who have endometriomas, and having those removed, we know could potentially reduce your ovarian reserve. So that's why, unless there is a patient who potentially wants to try and get pregnant naturally and avoid IVF, those are the patients that I encourage, go do laparoscopy first.
Mm-hmm.
My approach to care is diagnosis before treatment. And if your diagnosis before you even start a fertility journey is endometriosis, and even though you've been counseled about how endometriosis is a fertility threatening condition, you don't want to preserve your fertility, that's fine. Surgery could potentially increase your chances of getting pregnant naturally in some cases. So if a patient would like the option to do that and doesn't want to do embryo creation, then I think there is a role for surgery first, obviously. But for those patients who are planning their IVF journey, I would say IVF first. Then if you don't have healthy embryos or just no blasts, then surgery, then go back to IVF. But I would say prioritize IVF first, but then do surgery either when you're done with all your IVF cycles, because of how IVF can stimulate endometriosis. You don't want to do IVF, do surgery, and then have endometriosis come back. But at the same time, some patients just need to have their endo removed in order to have a successful IVF cycle. You just don't know if that's you until your first cycle. So part of your, the patient should be told from the very beginning, it might take more than one cycle for you to achieve your goals.
Mm-hmm. And I'm going to give you another case scenario because this seems to be my week. This week and next week is my week of giant bilateral endometriomas. I don't know why, it's like something in the water, but everybody has a 7 centimeter and like a 5 centimeter endometrioma. And, they're asking me IVF versus surgery first. Some of them have already had IVF for years and failed. Some of them are asking me if they can even go through a retrieval with endometriomas that large. And I told them, and correct me if I'm wrong, but I told them it obviously depends on the specialist doing it. And if technically Dr. Aimee, feels that you can get the eggs carefully and safely while enlarging the ovaries even further and getting them, then great. But I told them I would be on short sort of standby if the endometrioma is ruptured, that we can go in right away and clean everything. And so that was sort of my, before and after situation with that. And I think it's an interesting question for patients that do kind of come to the table with very bad endo like that. And then what do you do? Can you get them safely? Do you sometimes go transabdominal? They're asking me all these questions,
Mm-hmm. Yeah, you can't know until you actually see your fertility doctor. And then it's really based on their experience with endometriomas. They're, also if you're in a big center with 13 doctors and there's a different doctor of the day, you don't want to be at a center like that doing a retrieval with someone who's never met you before and has never done an ultrasound on you.
Mm-hmm.
So you want someone to kind of map out the exact approach that they'll take to keep you safe, to prevent an infection, to prevent rupture. And you're right. I'd want you on standby and say, I'm going to do your case. And if something happens, luckily, in all these years, I haven't needed to have someone on standby who has endometriosis from an endometrioma rupture. But you're right. That's exactly how I'm thinking when I'm planning out a case for someone who has a 7 centimeter endometrioma as they're going through IVF with me.
And do you see, I saw on the sonogram this week that a lot of those follicles So the follicles that you would retrieve to get the eggs from there, most of the time with a big endometrioma, they're really pushed to the periphery, kind of like a little halo around the endometrioma, right? So they're not like all in it, they're really on the periphery. So hopefully they'd be easier for you to get that way. But depending on.
Right. And I always tell patients, as you grow follicles, some of them actually might be endometriomas. You don't know it until you drain the follicle. But I tell my OR tech and I say, as soon as you see brown, you stop, you tell me, and we're going to switch out the tubing. We're going to flex the needle. It's not just, it's like we want, and the tube, like we don't want endometriosis to get anywhere near the eggs whenever possible.
And that's a great one. Do you find with those eggs that are in endometrioma fluid, do they survive? What happens with those ones,
Yeah, I mean, we just don't know. I don't do follicle mapping or egg mapping and track that egg that was, let's say, in a follicle that had endometriosis with it. It's a really good question. I mean, theoretically, that egg might be less viable than an egg that wasn't being bathed around endometriosis.
And then if they had trouble with the egg quality on the endometrium around, then like you said before, then they could be eligible to remove it, clean everything, and then try again,
Right.
fresh. So,
Yep. Mm-hmm.
Okay, let me see. And I think that's a great, and it's an important point, even with endometriosis surgery, like Dr. Aimee was discussing, it really depends on the technician and how the surgery is performed. And with ovaries, with endometriomas in them, in patients that are going through fertility, even without going through fertility, we always want to preserve all the follicles that we can and really not disturb them. So when we do this dissection, we try to really just use irrigation fluid, just like water, to dissect the cyst wall off of the ovary. And then we repair the ovary with suture, actually. Instead of burning it when it bleeds, we actually repair it with suture to stop the bleeding that dissolves in 6 weeks. So the goal is really to reduce any sort of lateral damage or collateral damage to any of the follicles there. And so as much as possible, if you are a patient out there examining with large endometriomas, the questions that are good to ask are, how do you perform the surgery? What happens if you get into bleeding in the ovary? Are you going to take out the ovary if you get into trouble? How do you repair the ovary? Do you not repair it? How do you dissect the endometrioma off? These are all great questions technically to sort of gauge, if your consent form says, if I get into trouble, I'm taking the ovary out, then that's not going to be a fertility enhancing and conserving surgery for you. So let me see. We had some other things on here. What are some strategies, Dr. Aimee, we can talk about for diminished ovarian reserve? Some insights for patients that may have deep endometriosis, diminished ovarian reserve. What are some things that they can try or opportunities to ask for with their fertility team as well?
Well, some of these things they're not going to get from their fertility team, but I'll share with you some of the things that I do. So some of the things that you can do on your own are take supplements, take an NAD booster, so something to replete and increase NAD in your cells to help with the mitochondrial health of your eggs. Using red light therapy can help decrease inflammation potentially and help with pain, especially in endometriosis patients. There is an experimental drug that I use now called rapamycin. I have found that 60 days on rapamycin is also studied, I think, in the late 90s as a way of treating endometriosis as an mTOR inhibitor, and it delays ovarian aging. It increases AMH after about 60 days in patients. So I use that now a lot in my practice because I have a lot of patients with decreased ovarian reserve and endometriosis. And I also offer patients PRP, which is an ovarian rejuvenation procedure, taking PRP or platelet-rich plasma from their own blood and infusing and injecting it into the ovary. I also use letrozole in my cycles. So letrozole is also known as Femara. It's a medication off-label that's also used to treat endometriosis because it suppresses or dampens the estrogen rise that we can see when patients take IVF. So I sometimes continue that medication daily during a patient's IVF cycle. So those are some of the strategies I use to improve egg quality, to increase the egg count. And, not every patient is going to have access to these things because there are doctors who just don't do these things. But there are doctors like me who offer both rapamycin and ovarian PRP now in their practice.
And how often does they're asking, how often does diminished ovarian reserve and endo present together?
Very often. I mean, endo is the culprit in a lot of cases. Endometriosis is fertility threatening. It can cause decreased ovarian reserve. It makes the eggs age faster than someone who does not have endometriosis. Even if someone has a good ovarian reserve, and if they have endometriosis, it can make the eggs perform biologically older than someone's chronological age. So, I consider endo something that should be taken very seriously. As soon as someone's diagnosed with it, they should get their AMH level checked. They should think about preserving their fertility. They should talk about a timeline that will give us the best chance of having the family that they want, so that they don't wish that they had known things sooner and earlier.
Like me.
Yes. Yeah, I know.
Yeah, and I think that's the exciting thing that, we have moving forward and we have today, right? That wasn't, I was an endo patient long ago and it wasn't an option when I was younger, and my mom and my grandmother all had it, but they never had these options. They were just all told sort of like, have babies when you're 20, 22, and then get it over with and then you'll be fine, but it's not always the option now. So I think, the fertility preservation is really great. And then, for everyone watching, really doing it with a protocol and someone that knows endometriosis is really important. Otherwise, you can be on very high estrogen load for a disease that's estrogen sensitive. And so, I get patients all the time that ask me if their endo is back after 1 or 2 rounds of IVF after surgery. And it's a good question. It's a great question. I think that even the estrogen alone, it can make you more sensitive in spots where you used to have endo. It doesn't mean necessarily that there's always going to be a new lesion if we looked inside. However, I do think that endo patients are sensitive to estrogen and maybe it causes a little more inflammation in the gut and different things like that. And so, I think it's always super important to have knowledgeable fertility doctors like yourself that are really experienced with endo and deal with it every day and know all of the tricks and ways around with it, right?
Right.
Okay, let me see. And we had some other, we've had lots of questions come in, but let me see if I have some other topics for Dr. Aimee first. How can, I think this is a good one for really patient advocacy, and Monica, you can speak to this too, but how often do how often do reproductive endocrinologists miss endometriosis or even bring it up in practice or their questionnaire, or is it a part of the discussion in mainstream fertility care? I find in my own experience that patients are really having to bring it up most of the time, more often than not, than it being mentioned as part of the fertility questionnaire. What do you think?
Yeah, I absolutely think it's missed every day, all day long. And I feel like one of the first questions patients should ask their doctor is, do you think I have endometriosis? But the thing is that even if they say no, if you and your gut think you might because you have the symptoms, you don't need someone to tell you.
Mhm,
Right? You don't need validation from someone.
mhm,
So if you think you have it, just go right to someone like you,
mhm,
to Dr. G, to Karli. Go right to the endometriosis expert. Go right to a MIG surgeon. Because if you spend time with your OBGYN, spend time with your fertility doctor, and you just think in your heart, like, I think I have endo, but they keep saying you don't, you're just wasting your time.
mhm.
So go to someone who has expertise in it, and they'll tell you what they think based on physical exam, based on pelvic ultrasound, maybe an MRI, maybe some blood work. And then maybe you will choose to do a laparoscopy, but you at least won't waste time trying to figure it out.
I
Right.
think from a patient perspective, it's interesting though, because even if you're someone like me who I'm a pretty strong advocate for myself and I like to research and I like to ask questions, I didn't know to even ask about endometriosis because at the time I didn't know what it was. So I wouldn't even know to like go to an expert about endometriosis because I didn't know what endometriosis was. And so it wasn't until speaking with you, Dr. Aimee, that I learned more about it. Now I think that's changing though, because we're having conversations like this and it's much more upfront and people are learning. I mean, talking to people now about endometriosis, even just 5 years ago compared, is very, very different. Like people know what it is, even if they just have like a baseline understanding of it. But I think that as a patient, that was like one of the things that was really challenging was like without your care, I was really like trying on my own. It took so long and no doctor did ever bring it up to me. Like you said, it doesn't seem to be very, it seems to get missed all the time. But if you don't even have the language as a patient to even know what to ask or what to look for, it can be really challenging to navigate. So I think that's why conversations around this are really important. And I will like tell anybody who ever asks me, like, please, please, please don't just go see your regular OB for this. Like there's like, and it took me like 2 to 3 years, like I said, from the time that we were like, yeah, we think it's endometriosis to actually find the right surgeon and the right person that I felt was taking like a very individualistic approach with my body and my care and my situation. Um, and I think that can be kind of hard to find. And even though, and I came with a lot of symptoms, but all of my diagnoses besides the DOR, really like my MRI was clean. So yeah.
The analogy is like if you needed a heart transplant, you wouldn't go to a general surgeon that's just,
No.
the appendix. You'd go to like a cardiac transplant surgeon. So it should be the same thing. You don't just go to a regular OB/GYN for a really advanced surgery that requires special skills and attention to detail in the way that only someone who's trained like Karli can do.
Yeah, I mean, I think, and that's part of what's in their wheelhouse and what's in their toolbox, right? And so if they're taught in training that the way to treat endo is birth control or the way to treat endo is Lupron, then it's not going to be in their wheelhouse to recommend excision surgery. And and so I think that's always difficult. And someone was asking earlier about endo mapping and pictures, and Monica, you just brought it up about your MRI. MRIs are amazing. They're great, but with a grain of salt. I operate every week on multiple cases, and every week MRIs are wrong, and they underestimate by 30 to 40% what's actually happening inside the pelvis. And so when an MRI is totally clean, then I can pretty confidently say that that day maybe won't be a certain amount of hours, maybe won't be a bowel resection. But I mean, there are surprises all the time, even with the bowel. And so, I think it's something that every single day my PA now, helps me, and she is always taping everyone's story onto the robot so I can read everyone's symptoms and go through all where their pain points were while I'm operating, and I can keep looking at it to make sure I got all of their points. And every day I'm like, what did this MRI say again? And I'm like yelling at I'm telling everyone in the room, can you believe this MRI? And like every day they're probably like, yeah, I know you say this every day, but the images are so off, and it's super frustrating. And, it happens all the time, but we can do as much mapping as possible and as much imaging as we want. But the best endo mapping is the patient's story and their symptoms. Every day when I look back at that symptom list, I have left-sided pain that goes down to my sacrum and my butt only on the left side. It goes up into my shoulder, and then it's exactly where they're talking about. And so as good as imaging is, there's no replacement, in my opinion, for actually a pelvic exam and really listening to someone's symptoms. And so, and that's the truth with being in the OR and even having the best radiologists and the best imaging facilities here and all of these things. It's still their resolution just misses a lot of endo. A lot of endo doesn't pick up on MRI because they want it to be half a centimeter or a centimeter thickness. And a lot of endo is more sessile and it's 3 millimeters or less in thickness. And so it just doesn't pick up. So I think that's a big problem with where we are today. There's some exciting things on the horizon in Australia with blood tests, and hopefully it will be mainstream soon, but we don't have it yet. It's going to take some years in the US probably to approve all of that. We have a lot of questions on, let's see, making embryos, if they should do more egg retrievals. AMH is normal, 22 egg retrieve, 2 embryos made, quite a few endo symptoms, uterus and ovaries fused together, painful intercourse, probably egg quality issues. So, patients are asking sort of those same questions on if they should investigate it further,
Yeah, I mean, from my perspective, the answer is yes, absolutely.
Yeah, definitely. I think worth a conversation and a look a little bit in more detail, and I think it depends from your perspective too. if they're doing, how many egg retrievals can they do, and it's like, do they have a package of 3 of them, or they can do 2 or 3, or, it's sort of like we discussed before, if you can do one before, then do the cleanup, then do another one, then great.
Mhm.
Some opportunity to see how that really does affect, the egg quality. 3, let's see, diagnosis diminished ovarian, low AMH, low AFC, 3 stim cycles, finally had success, pain lessened with age. Is that typical with endo? Um, I don't see that all the time with pain lessening with age, but I do think that if a patient has had pregnancy, it's sort of an old thing to tell patients is to get pregnant, and that will help their endo. I think if you have, it doesn't say in these comments, if you have had a pregnancy, pregnancy often does help the endo symptoms while you're pregnant because it's a high progesterone state and you have several months without a period and without ovulation. And so I do find that endo symptoms itself often do get better in those moments. And patients may report feeling better with breastfeeding as well because it's a high progesterone state. Most of the patients that come to me after all of that say, the minute they stopped breastfeeding, they noticed more symptoms again. And when they were sort of having their normal hormone swings again during the cycle. Okay, let's see. Yeah, what kind of questions should patients present to their fertility doctors or their other doctors? I mean, we've talked about a lot of this already, really bringing up the question of endometriosis. And if they offer endometriosis specific protocols, if you really strongly suspect endo and you have a lot of the symptoms of it, then you want a fertility practice that really is able to focus on that and give an individual approach, right, Dr. Aimee, and not have a one size fits all for every single patient.
Mm-hmm. I mean, I think one of the most important questions to ask is, do I have adenomyosis?
Mm-hmm.
That gets missed so often. And women with endometriosis have a higher likelihood of having adeno, which is basically inflammation in the walls of the uterus. What I find so heartbreaking is, patients with endo go through so much. They do years and years of IVF, and then they're ready to transfer. And then they've basically run through all their embryos until they see someone like me who's like, oh, hey, did anyone tell you you have severe adenomyosis? And that's probably why none of your embryo transfers have worked. And that should not happen. So that should be part of the conversation before your very first embryo transfer. And I always tell my patients that it is very important for you to know if a surrogate without adeno would give you a better chance of a healthy pregnancy. And I need to get you to that point when your embryos are so precious and you've worked so hard for them that I can say that your chances are going to be just as good as the surrogate's chances. So that's kind of how I approach care for women with endo is make sure that you've ruled out adeno. If a patient has adeno, make sure you've treated it adequately. Counsel the patients about what her risks in pregnancy are from adeno, especially if it's severe, because it should not be taken lightly. You can have very serious complications from adenomyosis in pregnancy, and it shouldn't be one of those things where you just walk into pregnancy with severe adeno and are not warned. You should be warned ahead of time so that you have the very best specialists, OBGYN, people to take care of you if you choose to take the risk to do that.
Yeah, I think that's a great point. And I mean, surgically, adenomyosis is a nightmare. It's very hard, tricky. We can't, I wish I could. I can technically remove adenomyosis, but when it's diffuse and it involves the entire wall of the uterus, it's sort of like having little tiny cystic focus all over, like stars all throughout the wall of the uterus, and you can't possibly remove every single one of them. And so, and in those cases, even if you do remove as much as possible, the native tissue of the uterus is not as healthy after years of adeno. And so it doesn't repair as well. Even if you put 3 or 4 layers of suture or stitches in there, it can break down, and it can break down in a pregnancy, like Dr. Aimee's talking about. It can cause catastrophic outcomes in pregnancy if the uterus breaks down and cause early rupture and, things that we don't want to be doomsday about, but it's very serious. And I think that, technically it's fine to remove fibroids and you can repair the uterus and it will heal really well. But adenomyosis is a different story, and there's a lot of targeted treatments for it. However, not all of those are proven to be effective before pregnancy. Uterine artery embolization, where they embolize the arteries to the uterus, is contraindicated to try to carry a full-time pregnancy. Microwave technology, I saw someone posting about this the other day for adenomyosis. I don't know the pregnancy outcome and the data on that, on if that's safe as well. I'm not sure the studies on that are as robust. I know obviously Lupron suppression pre-transfer has been successful for a lot of patients and can improve the rate of success, but obviously with thorough counseling and that they have all of the options, available. And I think it's good to, how do you treat adeno properly before embryo transfer? Yeah. I mean, I can let you speak to this one.
Oh, yeah. I mean, there's several different options. I mean, I go through them. I give patients my survival guide. So I have a survival guide of how to get through suppression. So you can go to my website and search in my blog, survival guide, and it'll come right up. It's just literally all the things that you need to know to survive it, because it's called Depo Lupron, but I really call it Devil Lupron because it makes you feel like you're possessed. You're more than just spicy. You're spicy and just feel awful. So if you're not prepared for that, you might think that something's terribly wrong with you and you're going insane. So I actually prefer Orlissa because it's a pill that you take twice a day. You can adjust the dose. There are different doses. If a patient's not tolerating the twice a day dose at the higher level, then we can reduce the amount of medication and go down to one a day. With Depo-Lupron, once it's in your system and you hate it, you're screwed. You have to tough it out. You're hosed.
Yeah.
So I like to give patients the option of being able to stop the medication if they can't handle it. So I will measure a patient's uterus, look at the volume, and then I can kind of say to her from the very start how many months I think she'll need it. And typically, what I'll do, if I just think it's probably going to be 2 months, I'll have her come in at the 2 month mark. We'll measure the volume again, and then we'll start transfer meds. Sometimes I have patients maybe just like the tiniest little bit, and I'm like, I think you'll be fine with just 1 month. But there are some patients where I say, I just want us to go with the flow and just kind of be open to whatever we might learn, because we all get so tied to these timelines. We want to do things at a time that we're told, and it's really disappointing to be told like you have to do another month if you weren't prepared for that.
Mm-hmm.
So I'll tell patients there's a chance that we might do a third month, maybe a fourth month. So let's just see how things look in two. And then we'll look at your volume and see how much improvement we've seen. And if I've seen an improvement, but not enough, I might want to go one more month. In addition to the suppression medication, I also add letrozole 2 tablets a day, norethindrone, calcium, other supplements like their NAD, CoQ10, and NAC, as well as their red light.
And so are you seeing a measurable difference? So for patients watching, like, when we look at adenomyosis, sometimes we'll see one uterine wall is 1 centimeter thick and one is 3 or 4 or 5 centimeters thick. So will you see a measurable almost symmetry in the walls after 3 months of that suppression?
No symmetry, no.
Yeah,
So
but you'll see a measurement reduction in the cystic quality.
Significant, yes, absolutely. Yes, the asymmetry remains, but the overall bulkiness is reduced, but not to the point where you would say that this patient does not have adenomyosis.
Right.
Most of the time.
Yeah. Okay, great. And Dr. Aimee just touched on, she has a survival guide for a lot of these, which is really awesome. And I think it is true. And, one of the things that's so unique about your practice and really great is that you do have so many tips and tricks for patients and survival guides and things like that, rather than just sort of, here's the meds, go pick them up, do this,
right.
And you have no idea what's coming, right? And I think that, I know, Monica, you went through it. We were talking about this the other day. It's like all of the IVF rounds, I tell patients I had every size from 0 to 14 in my attic from all of infertility treatments I went through. And I had to just be okay with it and be like, okay, well, and one day I'll get myself back after all those years, but it's a road trip, so it's not for the weak of heart on things like that. But it's important to have all these tricks and people that understand and actually listen to it. It's awesome. Let's see. We have Monica, we had some questions about embryos and post-surgery retrievals,
Yeah, I mean, so I've done 5 rounds of IVF, tried embryo creation prior to surgery. We had some success. I mean, I've made embryos of varying qualities, but I wouldn't say, I would say my retrievals are very emblematic of somebody with DOR and egg quality issues. And after surgery, I mean, at the time we did surgery, I'd already done 5. I was like kind of hoping we were done, but we're still not there. And I am really interested to potentially pursue at least one other round. That was kind of our intention going into surgery was, okay, we've done this 5 times. I'm really struggling with my life. My quality of life is not doing so great. So why don't we, let's move to surgery, try to improve that, and then see also if it makes a difference in my egg quality or in my retrievals. We haven't done that yet, so I don't really have like a definitive answer on that. But I mean, you feel your body, right? And I would say, I don't have these massive bloating experiences anymore. I'm not having severely clotted periods anymore. I am seeing a very large difference in the symptoms of my cycle, and I'm hopeful that maybe that correlates to an improvement in egg quality. I also have done 3 rounds of the ovarian PRP, ovarian rejuvenation with Dr. Aimee, and we did see really big improvements in my AMH there and the number of eggs that we collected. So potentially, if I was to go back into another IVF cycle, maybe trying those together along with the supplements that Dr. Aimee was mentioning. I'm a big fan of my red light therapy. And then absolutely taking NAD and all the other various supplements that might improve my egg quality as well.
And they're asking about, have you had to make lifestyle diet changes? I mean, I think Tory diet, exercise, things that are always helpful.
Yeah. I mean, generally speaking, I try to make healthy decisions for my life. And then obviously while we were going through IVF, there's a lot of conversation around that. So for sure, there were things for a while that I was cutting out to hopefully improve pain symptoms, but then also potentially improve my chances of creating great healthy embryos. I would say since surgery, it actually hasn't really been the forefront of my mind because it's been such a difference. So like I would say that I'm not doing anything anymore. It's such a big difference. I can't, and I can't say that this is going to be the experience of every patient. But yeah, I mean, before it was like I had like a whole system. It was like red light therapy and acupuncture and supplements and no gluten and no dairy and like low sugar and just like focus so much on all of that. And I would say like on the other side of it, I just haven't had to focus as much on it because it's not the forefront of my mind anymore. I'm not constantly in fear of like another flare up or if tomorrow I'll be able to walk. That isn't part of my daily routine anymore. So I'm really grateful for that. That said, it probably should be maybe a little bit, especially if I'm still considering doing it.
You've got a well-deserved vacation from all of that, so
it has felt like a vacation. It's been pretty great.
And we wanted to touch on sort of what healing can look like. I think, Monica, you're a great example of this, that I tell patients all the time that someone told me when I was really struggling with infertility years ago is that if you're flexible, you can have a baby, right? And they're like,
yeah.
Sometimes if you have a rigidity of thinking on it has to be exactly this way, or to Dr. Aimee's point, exactly this month or this timeline or this, then that creates sort of sometimes an obstacle that you can't really get past. And so, it really helped me when I was going through all of that to go on sort of a deep dive by myself online, like gestational carriers, egg donors, sign up for accounts, pick profiles, do all of these, kind of look into like, call an adoption agency, talk to an adoption attorney, figure out what would happen if I needed to do that. I literally went through I sort of attacked it like a medical problem or medical school or something. I was like, okay, what are all the options? And how could I get a baby? If I like showed up at this place tomorrow, how could I do this? And I think that's really important. Why? Because even if you don't go through those avenues, that they're there and it takes a little bit less pressure off of you. Sometimes it is a male factor problem, but a lot of times it's on us. And so I think it takes a little bit of pressure off when you're dealing with it. situations, right?
I mean, I think information is power, and I've learned to be more flexible over time. I think probably I arrived to Dr. Aimee slightly inflexible, but I've had to learn patience and yeah, flexibility and more openness. It's interesting, everybody's going to be different. Part of our journey is if we want to have biological children and put our embryos to use, will be through gestational surrogacy. And interestingly, like that has been, I didn't find that transition to be too much of a challenge. I don't know if other people in my position could relate to this, but there was some relief in sharing this experience potentially with somebody else because I felt so much pressure on my body and I didn't feel like my body was a safe place necessarily. I was struggling with my own body and what I was experiencing internally, and then also concerned about how it could potentially affect a pregnancy and how my mental health might struggle throughout that. So kind of being told like, hey, the only safe way, if we look at all the risks, best choice forward for you bringing these embryos home is with a gestational surrogate. I don't think it took me too long to have to adjust to that way of thinking because I think it just took a weight off of me. And at the end of the day, a healthy baby is what we want. And so we're open to how that comes to be. And then hopefully through all of the education and understand everything I've gained through learning about endometriosis and about my body, and then what I've put myself through in terms of surgeries and treatments and everything pays off down the road because I'm able to lead like a healthier, fuller life for my potential child than I would be if I was still sitting with that pelvic kidney all twisted around and stuck to my ovary.
That's right. Yeah. Healing is important even for, even no matter how big your baby comes, right? That
Yeah. And
you're feeling really good to take care of it one day, right?
yeah, physically and mentally, it's been a really big change because there did come a time, like probably I would say, talking about how IVF can, worsen your endometriosis symptoms. It certainly must have for me because it just went downhill so fast throughout my cycles. Um, and being able to kind of put that, I mean, it's not necessarily behind me because it's not necessarily a cure, but being able to like put that aside and then like focus my energy elsewhere has been a really big gift that I didn't know was going to be possible for me.
Well, thank you so much for sharing your story. Dr. Aimee, do you have any key takeaway points or reminders or tips for patients struggling with endo and infertility?
I mean, I would just say, surround yourself with people that believe you and listen and support you. And if you're with a clinic that doesn't quote unquote believe in endometriosis, they're not the right place for you. So trying to convince them about the science is just going to be a waste of your time. But I was thinking as we were talking, we've had so many car analogies, like your what did you call it, your road trip? And I was like, how is endo like a road trip? And I was thinking as Monica was talking, I mean, it's like being in your car and you want to get somewhere, but like you can't see, like your windshield is all foggy and you're just trying and trying. And it's like that egg is leaving the ovary, but there's like this endo there and it can't get to the fallopian tube. Like sometimes it does, like sometimes if your windshield's foggy, like sometimes you can make it to where you want to go without crashing. So it's like possible to get pregnant with endo, but a lot
Yeah.
of times it's really, really hard and dangerous for that little egg to make that journey. So, anyways, that's just what I was talking about as Monica was talking so eloquently. That's what I was thinking about.
Yeah, yeah. And I see that all the time in the ORs. Like when I get in there on these nightmare cases. I operated yesterday on, I was telling Monica, 2 cases and it was 14 hours of surgery. And
Wow.
the second one went through 8 rounds of IVF, many years, huge endometriosis, nodule on the back of the uterus, frozen pelvis, everything matted together, embryo transfers with all of this, failed Lupron suppression, and then finally just was like, I have to do something, and I mean, that's the reality I see sometimes, and it's awful to get that at like 42, and the chances are then and then I
Yeah.
need to try to pull a Hail Mary pass or a miracle in the surgery. And
Right.
I try, but it's still very daunting. In these cases, we get in there and the whole OR team knows, like when we open that pelvis and we see what's in there, we're all like, oh my gosh, no wonder that windshield was so foggy and they can't
Right.
see, is because everything is a mess and matted together. And how is this poor little egg supposed to make it? That's like the engine that could. So yeah, I think look, it takes a team, it takes a village and really creative mindset. And it's not impossible. A lot of patients will get pregnant with endo and can get pregnant on their own or get pregnant with IVF and can get pregnant with Lupron suppression with endo with IVF clinics. And so, there is a lot of data on that and it happens. But what we're really talking about here is if your story is not being heard, you're having trouble, you've failed multiple rounds with the same exact protocol over and over again, and you feel your endo is worse, your symptoms are worsening, and no one's listening, then it's time to think again about everything you're doing and get a second, third, fourth opinion, talk to people and find online communities and people like Monica who are advocating, right?
Well, I mean, I'm just advocating, but also receiving just as much support back. Community has been vital to my life as much as I hope that I can help other people as well. Um, I feel like, I mean, it's unfortunate in some ways that a lot of my education has come through other patient experiences and having to kind of collaborate on, this surgeon, that surgeon, this approach, that approach, and having to like group together a bunch of non-medical professionals to get there. But I think it's changing. And I feel really fortunate that I had such an amazing team. But I will say from a patient perspective, it took a lot of work on my end. And I wish it didn't take so much work on the patient who's already, emotionally and physically struggling to also the added burden of research and advocacy and trying to prove yourself to so many people. I'm so grateful that I didn't have to prove myself to anyone here after years of feeling like that was going to be the case if I was going to be heard.
Awesome. Yeah, I think, they're asking me on there, what did you wish you knew sooner? But probably that endometriosis was a word, right? And then
Endometriosis is a word, and that it's not normal to prescribe someone antidepressants because they're in pain, and that I know my body better than other people will know my body, and I can speak to my experience, and that should be listened to. And that also that no is a powerful word. Like you don't have to go with the first person that you talk to. I spoke to many surgeons. We talked at length about different options and their process and their strategy for dealing with my body. And they just because somebody says like I can take care of this for you doesn't necessarily mean that you have to say yes. And that it's your body. And if you don't feel comfortable, then you should take that like internalize that and think about why. And yeah, that you get to be in charge at the end of the day about how you want your life to be. Yeah. But yeah, I wish that I also knew how hard it was to get insurance to cover your surgery.
Oh yeah.
That's a whole different conversation.
A whole nother
Hopefully
conversation.
improving. Yeah.
Always working on it, but yeah, we're always fighting them. But yeah, it should be, look, we wish all of these were covered. We wish IVF was covered for endo. They were trying to make laws on it, right, Dr. Aimee, in certain places that it had to be covered for endometriosis patients as well. But they unfortunately, even when they make mandates like that, they don't mean always that it's covered with a specialist and it's covered with someone that really deals with that every day. And so that's an important sort of distinction. It may cover some basic care, but it doesn't mean that it's going to cover like targeted therapies and things.
That was the case with my plan, as it covered for certain people that I didn't want to touch my body.
Yeah, exactly. So, well, we're probably going to get cut off soon, but I wanted to thank you both so much for coming on tonight and having such an amazing conversation, and for always advocating for all of the patients out there in the endo community and the fertility community, the didelphys community, and everyone that you guys are advocating for. I think it's a really great thing for patients to have both of you as a resource. So you can find Monica on Instagram as Waiting for Baby Wunderman, right? Is that the exact spelling?
Waiting for Baby Wonder.
Waiting for Baby Wonder, sorry, yes. And then you can find Dr. Aimee on her website. She also has the Egg Whisperer podcast. She has books, and you can find her, is it draimee.org?
Yes, that's the website. That's right.
And she's also on Instagram, TikTok, lots of places, guys. So you can find Dr. Aimee everywhere. And her supplement lists are very easy to find as well. Thank you both so much for coming on tonight. It was an awesome chat.
Great getting to chat with you guys.
Yeah. Thank you. Thanks for this.
Thank you.